And so now I would like to move to Dr. Barbara Ma, who is a medical oncologist here at Weill Cornell Medicine, and she is going to talk to us about treatment of these non-melanoma skin cancers in the advanced stages. So Barbara, take it away.
Great. Thanks so much, Dr. Pavlik, and thanks so much to Sam and the AIM at Melanoma Foundation for this awesome opportunity. So today I'm going to be talking about advanced non-melanoma skin cancer treatments. I'm a medical oncologist at Cornell, and I'm going to be highlighting a lot of similar points that Dr. Del Guzzo touched on, but we'll go over more the systemic treatments. So skin cancers are the most common cancer in the US worldwide, with more people diagnosed with skin cancers each year in the US than all the other cancers combined. So you can see here, there are over 5.4 non-melanoma skin cancers in the US diagnosed annually. 80% of these tend to be basal cells, while 20% tends to be cutaneous squamous cells. And you can see that the non-melanoma skin cancers are 18 to 20 times more prevalent than that of melanoma, which is the most invasive skin cancer. Now, to go for the skin cancer risk factors, Dr. Del Guzzo did highlight a bunch of them, with 90% correlated with UV radiation from the sun. A personal history of skin cancer or precancerous skin lesions does increase the risk of skin cancers. A fair complexion, such as having blue eyes, blonde hair, fair, like light skin, having a tendency to sunburn is also a risk factor. And also tanning is also another risk factor. And one of the things that also Dr. Del Guzzo had highlighted is having a weakened immune system. So in, for example, organ transplant patients, they actually have a 65 times higher risk than the general public to develop squamous skin cancers. So either way, the biggest risk factors does tend to be sun exposure, weakened immune system, and then also personal or family history. So I'm going to start just by going through cutaneous squamous cell carcinoma first. As was previously discussed in Dr. Del Guzzo's talk, it is an abnormal growth of squamous cells, highly correlated with UV exposure. Then they can appear red and scaly. And most of the time, these are caught early in your dermatologist visit when doing the total body skin exam. And that's actually why they tend to have an excellent prognosis, because if you catch them early and address it early, then it's actually great outcomes. They only tend to get you in trouble if you kind of neglect them, allow them to grow more and become more invasive. And that's actually when the medical oncologists, us, have more of a role to play. But overall, the prognosis is excellent with early detection and mainly local management with the topical therapies, as Dr. Del Guzzo had mentioned, or surgery. But we will get into what happens if it tends to recur or becomes more locally destructive. Now, when we talk about stages, so when we're talking about more advanced non-melanoma skin cancers, we're basically talking about a small percentage of patients. So the risk of developing a nodal metastasis, or it becoming big enough that it spreads to a local lymph node, tends to be a pretty small percentage. Risk of recurrence tends to be 5%, and the chance of it spreading to a lymph node or a distant site tends to be 4 to 6%. But it's rarely metastatic, and really squamous cells, they can be more morbid if they're allowed to grow and you kind of neglect them. But there are a small percentage of cases where they can locally recur. And that tends to be certain risk factors, such as if it's a high risk location, such as the head and neck, or if it's a size that's greater than 2 centimeters. So this is just kind of highlighting about how do we risk stratify. So the NCCN is basically the national recognized standard for clinical guidelines in terms of how we care for this. And there is a risk stratification when we talk about low risk, high risk, or very high risk. And the key points from this is that high risk tends to be if it's a area that is really more readily exposed to the sun. So that's why it tends to be head and neck. And then if the size is large, and usually we use greater than 2 centimeters as being high risk, or if it's recurred in a previous site of the skin cancer, we also consider that high risk. And then such as the other risk factors that we talked about, such as being on immunosuppression. Now, in terms of treatment, Dr. Del Guzzo had gone over kind of the top part where she was talking about the topical creams and excision or Mohs surgery for superficial or smaller squamous cells. But in general, there's a whole team. It's very multidisciplinary, and that involves dermatologists, medical oncologists such as me and Dr. Pavlik, the surgeon, such as Dr. Minkus, at Cornell, like if it's a bigger squamous cell that needs margins through Mohs or something. We also rope in our pathologist who helps review all these cases. And then there's also nursing support, as well as in some cases our radiation oncologists if there are certain skin cancers that are not amenable to surgery. So it's a team effort. And the role that medical oncology tends to play is more in the advanced cases where if the skin cancer or the squamous cell is not amenable to local therapies or surgery or radiation, that's when we start considering systemic therapy. Systemic meaning something that's whole body that would get into not just the local site, but in sites that are kind of further away from the primary skin cancer. So to talk about the systemic treatment for cutaneous squamous cell, there's something called immune checkpoint inhibitor. So immune checkpoints, they regulate the immune system. And there are medications that kind of release the brakes, if you're thinking about like the gas pedal and all, to activate the immune system to attack cancer cells. And for cutaneous squamous cell carcinoma, and also for the other non-melanoma skin cancers, the 2 FDA-approved ones are cemiplimab, which is the other name for Libtayo, as well as pembrolizumab. The other name for it is Keytruda. And these are IV medicines that are given every 3 weeks. And these are examples of immunotherapies or immune checkpoint inhibitors that we use to activate the immune system to kill the skin cancer cells. And just to show you an example, so this is a patient who had advanced cutaneous squamous cell, and you can see he has a lot of nodular lesions on his scalp. And same case over here in this patient who had a periauricular cutaneous squamous cell. You can see that these are large lesions in high-risk locations, and even like just after 2 or 3 doses of the immune checkpoint inhibitor cemiplimab, you can see that he's had quite an impressive partial response. And then the other thing that we notice with the immune checkpoint inhibitors, especially for squamous cell carcinoma, is that the time to response is quick. In 50% of cases, you're going to see a response within 2 doses. So it tends to be very impressive and very rapid in onset. So this is an example of a swimmer's plot, which is just each bar represents a patient and the length is more the timing or duration of response. These responses to immune checkpoint inhibitors, they're not only rapid in onset and quick, but they also tend to be durable. So that's the main point of this swimmer's plot here. And then to get into basal cell carcinoma. So basal cell cancers are the most common. You can remember from that diagram earlier, they tend to be 80% of non-melanoma skin cancers. And again, it's pretty similar risk factors. They're most common in sun-exposed areas. They tend to be slow, locally aggressive growth. And you can think of how when Dr. Del Guzzo described them earlier, they're more like pearly, but they can have different ranges in appearance. But in general, they tend to be more pearly papules. Similar to the cutaneous squamous cells, when we talk about risk, we stratify them into high risk and low risk, basically on location. So again, head and neck tends to be high risk. or immunosuppression. And if it's recurred in a site of a prior BCC, that also tends to be high risk, and also size greater than 2 centimeters also tends to be more high risk. And again, it's a team effort. When we work with our dermatologists, our surgeons, our radiation oncologists, we are basically trying to decide what's the best treatment for a patient's skin cancer. If the dermatologist, is unable to address it locally with either topical, or if the Mohs surgeon can't get rid of it completely with Mohs surgery, then it usually goes to radiation oncologist to see, can we get rid of it? If they can't, then that's where the medical oncologist plays a bigger role in talking about systemic therapies. Now, the systemic therapies for basal cell are a little bit different for cutaneous squamous cell carcinoma, in that we also have another medication that we can use called a hedgehog inhibitor, which I'll get to on the next slide. But still, skin cancer, non-melanoma skin cancer management also, it does particularly require multidisciplinary teamwork. So for the systemic treatment options, the hedgehog inhibitors, they are an oral pill, while cemiplimab or Libtayo, which is the same medication that we mentioned earlier, is an immunotherapy. That's the intravenous one given every 3 weeks. These are the 2 systemic therapies that we generally use for advanced basal cell cancers. Now, for hedgehog inhibitors, again, it's an oral pill. It works on something called the hedgehog pathway, and that's linked to the signaling for basal cell cancers. And actually, they were thinking more like Sonic the Hedgehog when they kind of thought this. So actually, the first one that they had developed was called sonidegib. But then the one that is more of a later generation is called vismodegib. But either way, these are oral pills that you take daily. And they work very well for actually shrinking and killing the basal cell cancer cells. So what are some of the side effects for hedgehog inhibitors? So most commonly, actually, you can get muscle spasms. So that tends to happen in about 68% of patients. And usually we're able to manage this either with magnesium or off-label amlodipine, which is a blood pressure med. You can get some hair loss or alopecia with this, and that happens in 63% because the signaling pathway does overlap with the hair growth pathway. And then you can get some taste changes as well, which can happen in about 51% of patients. That usually we kind of manage these patients along with a nutritionist to help support basically making sure that they keep up with their diet in terms of eating. And then weight loss can also be seen in 46%. And but these are some of the most common side effects, as in you may have them, you may not, but in general, we balance this out with the benefits, which is actually, it has a pretty excellent response rate, close to 80% in shrinking the basal cell cancer. So that's why this tends to be the first line medication that we use in basal cell cancers that are not amenable to surgery or radiation or recur. And just to show you an example of response to the vismodegib hedgehog inhibitor. So this patient, he had a basal cell of the scalp, and you can see that 20 weeks in, he has actually a very beautiful response on that. And this is another example of how it's actually approved in both locally advanced and metastatic. So either spread to lymph node or to a distant site, we can see a lot of responses. And the other medication that I had mentioned was the immune checkpoint inhibitor, cemiplimab. That's also indicated for advanced basal cell carcinomas. And that's usually in the case of patients who couldn't tolerate the hedgehog inhibitor, either because of toxicity or the tumor got bigger after the hedgehog inhibitor. That's when immunotherapy cemiplimab is indicated. And it's not as responsive as it is in squamous cell carcinoma, but it is a pretty effective tool that we use. And you can see in this case that this patient who had a basal cell that was behind the ear, even after years on it, you can see that he actually has a beautiful response, on the immune checkpoint inhibitor. And again, it's just an IV infusion, 30 minutes every 3 weeks, and people really do have benefit on it. So in summary, for the non-melanoma skin cancers, particularly for cutaneous squamous cell and basal cell carcinoma. Usually you'll see the dermatologists who can see if it's a superficial lesion. Can they take care of it with local therapies such as like cryotherapy or topical creams? Or if it's bigger, can it be addressed by surgery or radiation? It's a multidisciplinary team effort where we help decide this. And if they can't, that's when us, the medical oncologists, play a bigger role. And that's when for basal cell, we can use hedgehog inhibitors first line. If that doesn't work, we'll use immunotherapy. Or in the case of advanced or metastatic cutaneous squamous cells, we'll most likely use immunotherapy. And the immunotherapy responses tend to be rapid in onset and also durable. All right, thank you.